we've got to address that person and give them a feeling that when they go in to see their internist or family physician, that that doctor has been in the loop as part of the decision making, and he or she has the tools that they need to help validate what's being done to them, and to affirm that it's really being done for them. Similarly, a frail elderly person with dementia, multiple hospitalizations, has to have that same accountability there, that that caregiver knows that the family doctor or internist is going over the full picture and working to keep their loved one out of the hospital and out of the grave. I would say that's my biggest initial challenge, and then ultimately accountability to the larger community that I'm doing performance-based care and high-quality care is important. Jeff, do you have anything?
I'm not a physician, and I come at this with 30 years as an IBMer and moving into healthcare software development and NCVHS work, and finally the development of health information exchange network. So there's this piece that you just described, Keith, where it's the community surrounding immediate patient care. I view health information technology as an enabler, not the solution. So there's so many communities I'm a part of to successfully have health information technology be successful as an enabler. And sometimes it's geographical, like within New Mexico. Sometimes it's the professional associations are the community. Sometimes it's state-directed, sometimes it's hospital or health plan-directed. But the other community that, that I guess I'm becoming increasingly aware of is the community of HIEs across the country right now. Because we're all going through similar experiences. We're not competing with each other. We really tend to share information and share how do we wind up solving similar problems. The state level HIE has been very effective in pulling this community together. And so I think I feel like it's related but not central to the community of the physician providing meaningful use in terms, obtaining meaningful use of HIT with direct interaction with a patient.
John, the other thing I would say is I think as the focus begins to shift towards health and wellness, and with equal focus to disease management, that your community will broaden dramatically. And we've been running a couple of programs now that fundamentally change the way I think of patients today and how they consume versus someone who considers themselves well and wants to remain that way and how they consume. And in fact, the consumption can be higher on that side than it is on the disease management side. It's part of their everyday expectation. So exercise and what goals they've achieved is something you want to do every day. When you have a chronic disease, you don't get up every morning going, I'm really excited to get this particular value today. It's important, but it doesn't drive my everyday thinking. And I think that we have to imagine a day when we are thinking about health and wellness, and it is part of your activities of daily living, and consumption will be very different in that setting.
And I would agree with what Martin said, absolutely, both in the context of wellness as opposed to health care, but also in the health care, on the health care end, thinking from the consumer perspective, even if you've got a chronic illness, dealing with the healthcare system is not your primary goal every day. I mean, people, no matter whether they're well or whether they've got a chronic illness, they lead complex lives. They've got families to take care of. They've got schools to coordinate with. They've got all this other stuff going on. And we working in the healthcare arena tend to hone in on our area of expertise, the healthcare system, but patients and consumers need for this technology to help them integrate their health and their wellness into their everyday. And I think back to your question about community, if you're talking about people with chronic illnesses, that really goes pretty far beyond the healthcare system, in the sense of, if you've got various healthcare providers, yes, it definitely includes them, but what about the adult care program that your mom is part of? Or what about the developmental program that your child with a disability is part of? Those are all considered outside the traditional healthcare system, and yet they deal with health information and generate health information much of the time. The school system, Department of Social Services, all of those. And so I think from the consumer perspective, that's a very important element of community as well, understanding that we've got to start to walk before we run, but that's important to keep in mind.
I think we'll take our last question from the audience. If you could stand up at the microphone and identify yourself.
My name is Saul Rosenberg. I'm a psychologist. I teach at the University of California, San Francisco Medical School. We've been teaching from a biopsychosocial perspective for 30 years, and yet the biopsychosocial perspective has been really quite neglected in the healthcare community, in the HIT community. It's actually even been neglected by the psychological community, who've been relatively absent from the debate. Well, that's changing. The American Psychological Association is much more interested now in participating in health psychology and primary care. I've recently been invited to join the LOINC committee to develop LOINC codes for the first time for psychological tests. I mean, imagine if we could, if a patient with a traumatic brain injury, we could order neurocognitive testing and neuroimaging in the same computerized provider order entry system. I mean, how much that would improve quality. In chronic disease management, psychological factors play a huge role in the quality and the cost. So my question is to the committee, what can I do, what can the psychology community do, and what organizations could I partner with to bring a biopsychosocial perspective into patient-centered primary care?
So could you stay at the microphone for a second? So I think this is a great question. I'm sure we'll all have very different takes on it. But I had a question for you which really relates to one of the challenges that we see in this space when we begin to talk about this aspect of healthcare are enormous concerns around privacy related issues. So in the world where you imagine that there is such a LOINC code, help me understand who would have access to it and how readily available would it be relative to, let's say, a laboratory test in your mind?
I think to start with, it would the order entry system, provider order entry system would have to be psychiatrists, physicians, and psychologists. They could supervise other clinicians working under them, but you need a doctoral level person.
And just one more, and the patient or the consumer themselves, would you imagine them having access to it?
Well, you know, imagine if a consumer had access to the questions from the Wechsler Adult Intelligence Scale. It's just not possible. It's copyrighted and it's used in many educational and legal contexts. So many psychological tests, the diagnostic psychological tests, are copyrighted instruments, and the questions are very carefully guarded because they have an enormous impact on society. So a provider who's authorized to order the test could order it, and then the patient could take it, perhaps even on a computer, in the physician's office, in a healthcare office. But the patient themselves would not actually order the test. Patients could take health quality questionnaires. They could report on psychological health issues in home health monitoring systems, but the actual diagnostic psychological tests would need to be ordered and then administered by a physician, psychiatrist, or psychologist.
My office is participating as a patient-centered medical home, and one of the features of the grant that I particularly like is having a doctoral level psychologist come to my office for about 4 hours a week and see patients of mine free of charge. And his data go into my record as confidential files. Only I can read it and my nurse case manager can read it, but none of the other staff. So that gives my patients some extra comfort. We are doing some rudimentary scales that are neuropsychological that are used in primary care, but one of the big obstacles for us is that we're a rural area and we don't have a lot of doctoral level neuropsychologists who do this kind of testing. So I can't really speculate. I would just be thrilled for my patients getting mental health services to get even an occasional correspondence from that person as to what they're actually working on and how it's going. And that's a big challenge right now, that communication.
Well, in the rural areas, there's a big role for telehealth. So given today's technology, there's no reason why a psychologist can't interview a patient, do a screening interview, and then actually administer tests on the computer right where the patient is.
Well, and from our perspective, we actually have folks from the mental health community who are part of the Consumer Partnership for eHealth, and they're certainly concerned about privacy issues, but they also, and I believe this is the reason why they're involved in our coalition, is the fact that they're very interested in having people who have mental health issues be able to be treated holistically, and not have the separation between mental health and then the physical health, clinical physical health. So I definitely think there's an interest there on the consumer perspective, and in terms of testing and access to information, it's important to have access to information that's useful. And if the information's in a format that only a doctoral level psychologist is going to be able to understand and apply, then it's not meaningful and useful to that patient. I think the important thing is how can the technology be used to either make that information useful to that individual or to support the communication between the provider and the patient to make use of that information. Otherwise, why do the test? But I mean, I'm sure there's a relationship
that is the point
there
of it.
Exactly. Yeah.
It's we can psychologists can assess with 10 or 20
Right.
questions whether a patient is likely to be adherent to a complex medication regimen.
Right.
That information can be very clearly communicated to the clinician provider as well as to the patient.
Right. Well, and that's actually, I think, our point is the point is not to have access to information for information's sake. It's to have access to the information that's useful, that patient can then take action on. And I think the action there would be a care plan and that's information that really benefits the provider in working with that individual to come up with a care plan that's not only addressing the clinical needs and then the things that we know are good quality, but what's actually going to be the most likely best benefit to that patient. And if it's an intervention that they're not likely to follow through with because of various reasons, then let's look at other options. So I think that's
And Mary Jo?
I actually just wanted to put in a plug for a hearing that I think will be of interest to people who are interested in this topic, and I'm sure many people around the table and perhaps on the phone know this, that since we're talking about how to engage patients in meaningful use issues. Next Tuesday, the 20th, there will be an almost all-day hearing on engaging patients and families in meaningful use, so that as the definitions and requirements for meaningful use in 2013 and 2015 are formulated, that we get this kind of input, and there should be a blog going out within 48 hours to encourage comments as well. So you, Dr. Rosenthal, if I got your name correctly, and anyone on the phone who cares about this issue, I hope that you'll pay attention to that and provide input.